on the latest topics to get insight on disease prevention and health issues. In today's Your Health Counter, we have eminent Dr. Purshotam Lal, a pioneer in interventional cardiology. He has the unique distinction of introducing the largest number of procedures in the field of interventional cardiology for the first time in India, such as rotablator stenting, balloon, mitral valvuloplasty, heart hole closer, TAVI, etc. He has been listed many times in Limca Book of World Records. He has been named as the father of interventional cardiology in India by Professor Adnan Kastre from Germany, a reputed cardiologist in the world. He was awarded Padma Vibhushan and Dr. B.C. Roy National Award by the President of India, making him the most decorated cardiologist of the country. Welcome, Dr. Lal, but speaking to him is Dr. Swadeep Srivastava, the founder of Heal Foundation and Heal Health, and one of India's top health communication expert. He has been at the forefront of healthcare awareness through healthcare communication and has been instrumental in creating campaigns and platforms for healthcare improvements in India for the last 2 decades. Over to you, Dr. Swadeep.
Good morning, Dr. Lal. Welcome, sir. Yeah. So hope okay, sir. So hope our voice is clear, sir. We can start the discussion.
Yes, we can.
Okay, sir. So we people like me in healthcare don't need introduction about you, and people in not only in Noida in North India but across the country and across the globe have seen a lot of pioneering work done by you, and the way you have been treating and working with your patients, particularly your motto of serving the middle and lower middle class in the country, is been phenomenal and such highly appreciated and decorated also by many awards and accolades which you have earned in your career of more than 3 decades, sir. I personally have been following you for the last almost 3 decades now, from your journey from coming back from US, having a very, very successful practice in US, then coming back to India in Chennai, Apollo Hospital, then Apollo Hospital, Delhi, because you wanted to serve your country. That's why I remember you came back to your you selected a place like Noida to build up one of the first dedicated heart care hospital, which then progressed into becoming a chain of multi-specialty hospital, and Metro is today the name to reckon with in the particularly in the certain segment of the society which comprises of a majority of our population, and they need heart care the most. So you have also been instrumental in bringing that access of to the people, heart care to the people of India, sir. And so what I would like to definitely know from you is, and we thought that this would be the apt topic, wherein with COVID, we have all seen the loom of COVID for the last 2 years now, and it has got a certain impact on the overall healthcare scenario. Also, our healthcare infrastructure have been tested. I remember your hospital in Noida, in Delhi, and in about 10 hospitals, what you have, they have also been tested with respect to providing exemplary COVID care in the COVID times, and what have been affected has also been the heart care. So this time we thought the topic should be, we should focus on the heart care aspect, which has been impacted, the rising incidence of heart attacks we see in the younger population, and so a lot of things which we'll be discussing over a period of time in this session, sir. Today in this episode, we have eminent cardiologists following after your session. But what most we thought was that if we can also learn from you the journey of development of interventional cardiology, because I remember 3 decades back when you used to work with Dr. Pratap C. Reddy, and Dr. Reddy always used to say that why he started Apollo Hospital, because he got patients and he was not able to provide them treatment, and for bypass surgery, for interventional cardiology, patients were forced to go to foreign countries like UK and US where the healthcare facilities are more developed. And that's why the intervention cardiology, the first the bypass surgery, then the interventional cardiology advent in India and its progression. Who knows better than you? You have been at the helm of it since day one, and a lot of pioneering things what you have introduced, which have revolutionized heart care in India. And I'm personally so gung-ho and passionate about your angiography from the wrist, because that is again which brought a revolution when you said that this is a metro heart screening. You walk in and you just walk out in half an hour, in 1 hour, by having a quick angiography, which is a gold standard for heart screening and detecting heart diseases. So with this, we'll start your PPT, sir, for say about 10 to 15 minutes. Then I'll have some questions from our viewers from across the world, which would like to pose to you, sir. So over to you, Dr. Lal.
Thank you, Dr. Srivastava. You have been very kind, and I can talk a lot about your contributions in the field of journalism. And I think when I got full time in India, you were the first one I started interacting, and that was in '97. And it has been a very pleasure to continue talking to you. And I found you always very genius and top of everything. And that's precisely you are doing now, by educating the people, making them aware, sharing the knowledge with each other. My field is interventional cardiology, and strictly I deal only with the wires, catheter, so forth. And I will go very quickly because it's a highly technical, and so I'll just take 10, 15 minutes. If we go back 90 years back, this was the gentleman in Germany who did the self-catheterization, and that's how the catheterization started. 75 years back, a lot of animal studies were done and how a catheter can be developed. And these are the great people, Dr. Gnutz, Jertkin, Sons.
So your slide is not moving on the screen. Is somebody moving it?
Oh, well,
Sir, it's moving now?
No, you have to share again, come back again. You just stop share screening and then share again. Stop screening and share again.
Yeah. It's not showing?
It's come now. Now I start moving. Yeah. Go to the next.
Is it okay now?
Yeah, now it's okay, sir. Can we go to the next slide? Yes.
So Dr. Gnutz in 77, he did the first angioplasty, and this was the balloon angioplasty. I'm moving fast. Dr. Machanda here in AIMS did the first coronary angioplasty in the country in '84. The right coronary artery on the left, you see the block and then the balloon, and then after the Dr. Sudeep, are you seeing now? Okay.
It is not moving. My other colleagues are seeing the movement. Shankar sir, is it moving on the screen?
No, Sudeep, it's not moving.
Oh, Pavitra, is there an issue with the moving slide? Because all the presentations come and move.
सर कुछ चेंज करना पड़ेगा।
क्या चेंज करना पड़ेगा प्लीज?
सर उनकी पीपीटी से ही कुछ हो रहा है, यहाँ से कुछ नहीं है।
Okay, sir. Sir, can anybody stop again and start sharing again?
Sir, sure.
Please, एक बार try कर ली.
वो तो दिख रहा हूँ दोबारा. So is it now showing?
Yeah, it is showing. Now it is showing.
Yeah,
It's
now
now
it's
look-
okay. Yeah.
It's moving now?
Yeah.
Next slide. Can you see, Sudeep?
Yes, sir. It's moving, sir. We can continue without.
All right. Well, since it's quite long, I have to go fast, so I won't go back. Now, see, in the balloon angioplasty, the major problem was that if the artery is 100% blocked, how to deal with that? And that was the device which we started in '89. And I was involved with Professor Carlton back, and we developed the prototype and then did the many cases just to show how it works. It's a slow rotation, like a battery. If you see the rotation, Dr. Sudeep, you are seeing the rotation?
Excellent, sir. It is coming a very good view, sir.
All right. Now, uh, after that, we found that it's not really cost effective. And we moved to, the new devices came where we will take the fat out of the artery. Let's say there is a block and it will cut and take the fat. This was the cutter. There's the real cutter, which we put inside the artery. And this is inside the artery. What you are seeing is inside the artery. But it did not reduce the reoccurrence. This was the problem with the balloon angioplasty. We had a problem of crossing the total occlusions, number one. Two, by the reoccurrence. And this cutting device came to prevent the reoccurrence, but it really didn't. Although it's supported to do with the many complex cases. And these are the first papers on this particular device in our country. A rotablator is here to stay. We use in our labs almost daily basis. This is the problem with our folks, is the highly calcified arteries. In India, we get small arteries, diffuse disease. On the top of that, it's highly calcified, where even bypass become difficult, but angioplasty, the stent doesn't move, and that's rotablator. It cuts the calcium, and this was the gentleman who helped us to bring the rotablator to the country. And again, it really didn't stop the restenosis, but we were able to do the angioplasty with the help of stent. Now you see, this thing is moving, and there are two arteries, and one is main, and you find the main is totally cut off from the other two arteries, the multiple blocks, and this is full of calcium. Nobody can really think of doing the angioplasty without cutting with the rotablator. I mean, it's not difficult. It is impossible, to do angioplasty, and that's where the rotablator. And you will see, that's how this cuts inside the artery. The black shadow around is the calcium. And that's how slowly we did. And this is just to show one example. See, it's the same artery. You were seeing the critical blocks, and now you see almost normal. And we saved the 81, 82-year-old patient from bypass. So that's really my, every day I get the patient who has been advised bypass, where the bypass is the only option. Either patient is too old, or due to many other concomitant medical problems where the bypass is not possible, or the patient doesn't want, or the patient is very young. And that's where, I can say that we can save almost 99% of the patient from the bypass. Now this is the before you see, and this is after. Now, moving, this was, on the first abrasion paper, rotablator paper, and then we came up with the stenting, coronary stenting. The first case we performed was in July 91, and that's, animatic model to show how the stent fits in the artery. Now, that's the real first artery, I would say, with the stent in Asia, if I will not say in India. And there was a block. It's a patient came from Maldives. In the beginning, we used to put the stent only to prevent the acute abrupt closure after balloon angioplasty, what we used to call bailout situation. On the left upper, you see the block, and then we did the balloon angioplasty, and on the right up, you see the totally occluded. And that's where we put the stent, and after putting the stent, that's how we started. This was of the first case of the country. And if you see on the left side, lower side, where you see the arrow, now this is the stent inside the artery, which we were very excited. This was first patient, and this patient still comes to me, after a period of, now you can see 50 years, and after 30 years, he comes, and he happened to be father-in-law of the current president of Maldives, and these are various publications on the stent, and when I see the publication, we have a lot of publication on each, but this is the first publication in the country, first presentation in the country in Indian Heart Journal, which is our main thing. And then comes, like gold stent. And see, in 92, when I was giving the lecture in Delhi, I made a statement, stenting is worse than the disease. That time we were not sure the stent will be a revolutionary treatment. And after 10 years, everything got changed. The technique got changed, and now without stent, we cannot move. Now this is the before, this is after, before, after. And that's the, we can put stent anywhere. That's the neck artery, to prevent the stroke. And this is the aorta. See how bent that aorta is on left side, and you see acute bend. This is right in the abdomen, and after putting the stent on the right side, you see it. And then we did the first case of abdominal aneurysm. On left side is aneurysm, and after putting the stent, it is the thing. And then thereafter we moved to mitral valvuloplasty. Sudeep, are you watching? You are able to see now slides? Sudeep?
Yes, sir. Yes, sir. Very well, sir. Showing, sir. Yeah.
Oh, all right. This is the balloon valvuloplasty. We put Inu balloon. Now, this is the best balloon in the world, and no other balloon could replace. And that I was able to bring to the country in 1990. I was the first investigator, and till today we use it even in the calcified valve to open it. And this was the letter which the Japanese gave. The cost was $3,000, but really I struggled to bring it to 1,000 for third world countries like India. And these are the publications of rotablator. And then we started doing the procedure with the help of echo, and this was our first patient where the patient was not able to afford the cath lab and so forth. And that's where we did. And now moving pulmonary valvuloplasty, this is just to give an idea. I'll skip over there because it's going wrong. Aortic, that's very important. Aortic valvuloplasty, that this was the one which we made a prototype artificial heart disease in 91. And these are all, I think, collected the things from various places and then made the device, did the first case in 90. And this is how you can see the videos that time looked like. It's the catheter inside the heart, very big, and that's how we open the aortic, and that's new device came. And what we call ampulla, and these days we call ECMO. ECMO, we started the prototype, initially we did supported angioplasty, and now we are using it, and same way ampulla. So these are the support system. There's the holes in the heart. PDA is the one that we started, and this is how the device looked like. And this was 12-year-old boy from Maldives, again in 90, which we did with modified technique. And now skipping further, there are many new devices we did in this. Now this device was this was the big thing, the closing hole in the young girl's heart hole. And this was my dream. A long story how it started, which I will not say. But this was monodisc. I was involved in the clinical development of this device. on 19-year-old boy. These are the animal studies, and this we did about 35 cases, and thereafter better devices came. That's how we closed the VSD, very challenging, and we started closing the VSD in a boy, 15-year-old, which was rejected for surgery, opened the valve as well as did the, the, so moving TAVI. TAVI, as you know, is costing so high. And when we started, the company who invented this was France, and I had an agreement with them that the cost will not be more than 3-4 lakh in India. However, later on they sold to Medtronic, and apparently the price went high, and now it is costing 15 lakh or more. I would say 15 to 20 lakh. Now this was the TAVI which we started in 92 when I was given this oration by the Cardiology Society of India. And this was the animated animal studies which we did in Anderson, how they replace the valve. And thereafter, it was not that successful, and slowly progress carry on. That was the time people laughed that how it can work. But the first catheter in the 2002 was done by Alan Crevier with a different device. And then this fellow, he invented the core valve. This is how the core valve looks like. And the all animal studies, this was the mutual understanding. And the first core valve uh, implanted in human on July 12 at 2004 at Metro Noida. This was big achievement. It made the history. Lot of countries are calling me now also to present the first case. You know how the it became the antique device, and this was the patient where we did. So due to shortage of time, I'll just skip over. It was just a glimpse of this was the, when the certificate was given, that is how we did the successful first case. So the core valve which we did was 21 French, and now it is available on 14 French, and we can do the case in 45 minutes of TAVI. And this was another where we don't have to prepare the valve. And me and Dr. Rievert used to work since 89 onward in Germany and did a lot of cases together. And this was the lady where we did a rapid case, both angioplasty as well as valve replacement in 45 minutes. Thank you so much.
Sir, very quickly, sir, it is very informative. We can have an hour-long session separately on this, and we'll definitely have, because there will be. So very quickly, what people would like to know is one is about this. Why don't we start with angiography with wrist, sir? So what is the difference? What is the genesis of it? Now I believe a lot of more other people would also be doing. But I remember 15 years back when you started, I don't know if many people were doing in India. So what is the advantage you saw? What was the genesis? Can you tell something about it, sir?
Well, see, angiography through the wrist or elbow was nothing new. When the angiography started in 50s and then in 60s in the world, they started from the arm itself, but by giving the cut and so forth. And later on, they started through the groin. And then came in India in 97, 98, the CT angio. A lot of people were going, and that time we were not that advanced with CT angio, a lot of radiation, so forth. And when the CT angio will tell anything, and then again we have to do the angio. That's how we developed this technique so that we can do in about 3 minutes. And we started with elbow, where the patient doesn't have to take the clothes. He will just walk in the cath lab, and we'll do quickly echo and blood test. And so by doing everything, the patient was able to go home, not home, to work, in half an hour, or certainly I will say give and take less than 1 hour. We have done more than 60,000 cases now. We presented papers, and our first paper was very long in UK. But anyway, it is better, and now it is done everywhere. so nothing new. And the people in the country, in Delhi NCR and everywhere, it is done very good. Our concept was different. I won't say it was new invention. It was more of a concept where we took the fear out of the people. The phobia of coronary angiography. People never wanted to hear the word coronary angiography. It was just like an operation, and so we gave the name metro coronary screening, MCS, and then a lot of people started coming, and later on they found it was really because there were a lot of modification. We followed physics formula that with 5 cc dye we used to do the angiography, and still we do it, and with that no physiological changes, and a person can just go back.
So quickly, two more questions, because our other cardiologist panelists have also come in. We have a very long 1 hour 15 minute session after this, sir. A lot of heart health related and COVID and heart health and young people dying of heart attack. All these questions will be answered, sir. But my question to you would be like this CT. Now this another new thing came up and was a lot of craze about it. CT angio. Then people started comparing it with angiography and how it can replace it. So what is your view of on that, sir?
Well, I think CT angio is a very, very good, and these are supplementary. It's not really, I would say, alternate. No, I will order CT angio if a 30-year-old comes to me, and where I'm reasonably convinced that most likely, even though there are risk factors, having coronary artery disease, the chances are very less. And that's the place where we order the CT angio. CT angio, in our practice, I will be ordering CT angio 3, 4, I would say every week. And then the angio, the advantage, the kind of in our institute where we deal with the low middle class people, sometimes they don't want to have two tests. First CT angio, and once I am convinced that there is a likelihood of the disease there, I would rather go, where what we call MCS, through the wrist or elbow, and that also takes, as I said, 3, 4, 5 minutes.
Yeah. Okay. So one last question to you, sir, is I being in healthcare, I have almost been getting got calls from few hundreds of patients for heart treatment and for second opinion. And so one of the commonest thing what I've seen is particularly in the multi-vessel heart disease, where more than about 3 vessels are involved with a blockage in the heart, sir. So there's always, I've seen a conflict of opinion. A patient goes to a cardiac surgeon and cardiac surgeon says that I will do the bypass surgery and it has become advanced and that is the only way to sort out. And there are certain cases where interventional cardiologists have seen that such can be handled with the proper professional angioplasty procedure also. So what is the difference of where patients should know in multi artery diseases that angioplasty is good, or of course is the call of the medical practitioner, but what patient should know about the benefit of bypass surgery over angioplasty and benefits of angioplasty over bypass surgeries?
Well, I will answer as short as possible. But Sudeep, I found you many times. You are not less than a cardiologist. You know all about this. And see, and likewise, a lot of people now, they are quite aware of, of the procedures. Those days are gone where the people didn't have knowledge. Now everybody checks with the internet, and taking second opinion, third, which is always very good. But now my point is that we divide the treatment in four. If I see one angio where I feel that it is the best for the patient to have an angioplasty, now this is the angioplasty. And there is a one group of patient which I would say the bypass is preferred. And then come the mixture. There we see the pros and cons, and fourth, of course, the medical treatment. Now, if I have a young patient and all the three arteries are blocked, and when I say young, say 40-year-old, 45, 50-year-old, I would prefer personally multiple vessel angioplasty. And if I have a patient at the age of 70, 68, I would prefer bypass because that's the best time for the patient to tolerate the surgery rather than doing the angioplasty and maybe, sometime when they become 78, 80, the surgery becomes relatively difficult. So we go by each patient. And then at the same time, if I have patient coming from, say, my village or any village, where we find, that patient will not be able to come for follow-up and so forth, and we want a very, very long-term result. Bypass is always better for the long-term result. The people coming from the villages sometimes cannot afford, because these days the angioplasty, when we do the multiple vessels by using road ablators and so forth, becomes more expensive than the bypasses.
Yes, sir. So what would be your message for this new year? Any health resolution, particularly related to heart health, when a lot of incidences of heart health in youth are also growing up? So what would be the message people should take care for coming from you, sir, in this new year?
Well, I tell you, for any heart health, I would say the ideal weight, by burning calories or eating and burning calories and exercise program, diet program. So these are the, a major thing to avoid smoking. And if somebody drinks, they should limit to moderate drinking. And diabetes, hypertension should be controlled. Of course, we have to deal with the stress where the role of yoga comes, and these are the, and then of course you will be talking on different places, the how to be, take the precautions from COVID.
Right, so please continue.
Yeah. So these are the, things a person has to care. And in totality, I would say that general checkups are very good. And the people who are heart patients, they have to be very careful, particularly in winter, and then they have to be more careful in this COVID scenario, what unfortunately whole world is facing, where the chances of getting cardiac events are getting more and more. I would say that probably the increased viscosity and many other inflammatory changes. So just do the exercise, eat good, eat healthy diet, and I think that will keep the people in a fit condition.
Thank you. Thank you, sir. This was wonderful, sir. We'll keep continue with you in our other series, sir. And thank you for coming and sparing time, sir. We got a lot of information. Our people, we definitely, our viewers are going to benefit out of it.
All right. Thank you
sir.
so
Have
much.
a nice
Very
day.
kind of you.
Thank you. Over to you, Shankar, sir. Shankar, sir, unmute, please.
Thank you, Sudeep. I think it was a wonderful session with Dr. Purshotam Lal. Quite a lot of information. Only regret is that we had to end it so soon. There are a lot of questions, I presume, that could have been asked, but we'll have Dr. Lal again in another session. We now